Thank you for thank you for your warm introduction, ma'am. So without further delay, I would like to go on to the presentation.
May Sangeet is happy to share. You're okay with it?
Yes, ma'am.
Okay, go ahead, Sangeet.
So I have designed the today's class in such a way I had written three cases that I had seen. These were, three patients who had experienced delirium in three different contexts. So I would like you to kind of um, see the three presentations and first try to kind of make note what are the behaviors that are seen by these from what are the behaviors seen in these people, that is objectively when you observe them, what are the behaviors that you are seeing and what may be the experiences of these people. Just try to think about what they must have been experiencing. Then we will go on to see what are the clinical features. So that's how we interpret in psychiatry. That is, we observe what behaviors are there in terms of what is the exactly the behavior, when does the behavior happen, what are the triggers, and what helps to reduce those behaviors, and trying to understand what may be the experiences behind those behaviors. So it is a small exercise kind of a thing. When I show you the three patients' histories, try to first make a note. If you have a pen and a paper, try to note the behaviors that are seen and what may be the experience. Then we will discuss them and then go on to the clinical features. Can you please show me the next slide? So this is Mr. Srinivas, who was a 70 years old male. He was staying alone in rural area of Vizag, and 3 days prior to admission with us, he had a history of fall at his home from his bed, during which he developed fracture in his femur, for which he underwent proximal femoral nailing under general anesthesia. So on post-operative day 2, he was confused, he was agitated, and he was trying to pull away all the IV lines and the Foley's catheter, and he was trying to get out of the bed. On examination, his pulse rate was 94, BP was 130/80, and he was having visual hallucinations. And when we examined him, he was disoriented to time, place, and person. There were no other focal neurological deficits. Next slide, please. So, the first case, can you show me the first Srinivas's slide, please? Now, I would let me see how much you are able to. You're with me, okay? So, whom can I ask? Can anyone volunteer to tell me what are the behaviors that are present in this patient? Or yes, Dr. Victoria. Is that how I will call him? Dr. Victoria? Confusion, okay. Agitation, then you can unmute yourself and speak as well. Hallucinations, he's pulling away IV lines, he is agitated. He is disoriented, okay. Disoriented to time, place, and person. So I will ask you firstly that in this patient, so he was angry, okay. So what you can see is he's very agitated, he's trying to pull away the IV lines and all, he's trying to pull away the catheter, he's always continuously trying to get out of the bed. So why do you think what can explain why he's trying to pull away the lines and catheter? It will be very nice if you can unmute yourself. So what we do in psychiatry is that we make a note of the various behaviors and then try to match with what usually causes these symptoms. New environment, new family, no family in the ICU. But why would he try to pull away the lines? He's confused and scared. But why is he so confused? Why is he so scared? What makes him so confused and what makes him scared? Okay, you can, we will go ahead to the next patient as well. And when we go to the clinical features slide, you can try to help me try to explain what may be the reason why he is so agitated, why he is trying to pull away. He does not want to be bedridden. Yes. Okay. So that can be one reason. ICU psychosis. Okay. So at ICU psychosis was the older name for delirium. Today, what we say as delirium was one day it was called ICU psychosis. The next slide, please. So this is another patient that we were seeing. So she was Kamala, who's a 55-year-old female. She was a fish vendor by occupation, and she was separated from her husband. She was diagnosed with carcinoma cervix stage 4 1 year back. She underwent radiation and then referred to palliative care in view of severe pain. So it can some Jayasudha tells me it could be due to metabolic encephalopathy like hyponatremia. Thank you. Let us go. So this patient had severe dull aching pain in the back, which was radiating to her limbs. It was continuous burning sensation in the perineal area. The pain was not remitting with morphine, and that is, she had hyperalgesia. In fact, when we gave her morphine, then we shifted to methadone. There was no relief. She was started on fentanyl infusion. Next slide, please. In the last few days, she had been restless, trying to get away from the bed, and her son complained that she has not been sleeping and not aware of where she is. Next slide, please. So though her pain improved later, she started becoming increasingly bedbound. She complained of severe fatigue and oral intake reduced. Again, even after the pain improved, there was intermittent agitation, disorientation, and over the next few days, her pulse volume was getting feeble, and her breathing pattern was gradually changing, and she was increasingly tired. After a few days, she passed away. However, she persisted in that state of delirium for 2 to 3 weeks with no other focal etiology other than pain, and she had desaturation also towards the end of pain. So, towards the end of her life. So, what were the symptoms that Kamala was experiencing? Can you go to the previous slide, please? Pain. Uh, Before that, fatigue. Okay. Um, Breathlessness. Mhm. Burning sensation. Pain, restlessness, insomnia, disorientation, fatigue, agitation, decreased oral intake. So she was experiencing several symptoms, of which today we are going to discuss symptoms that are related to agitation, restlessness, isn't it? So, and next slide, please. If you had seen, this is a little different from that of the previous patient who had a kind of acute onset of this state, this transient state, whereas the second patient Kamala had a more of an insidious in onset, and the duration of these symptoms were also a little longer in the second patient. And we had a few kind of focal signs like pain, etc., but not much other reason why we can have delirium. And over time, we got to know it could be due to terminal delirium when we saw the vital signs that were suggestive of end of life, isn't it? The third patient, next, next, next slide, please. So this is the third patient who was Rama, who was 75-year-old male. He was a known case of seizure disorder. However, he was very poorly compliant with medications, and he had history of alcohol use in dependence pattern. For 1 week, so the all these the complaints or the concerns for the patient's family has been since 1 week. During which the first 3 days he had multiple episodes of seizures, and after that he had been drowsy and confused. He had been having wayfinding difficulty at home. He was about to go, like leave the house and go somewhere. He was not knowing where he was going as well. He was intermittently disoriented, and he was having cough with expectoration. So what were the symptoms that Rama was experiencing? Or what were the behaviors the family members were seeing? Drowsiness, confusion, disorientation, drowsiness, confusion, is disoriented. So what were the family members? Cough, withdrawal symptoms, alcohol consumption. So the third patient, Rama, he is in the community. In contrast to the first, Srinivas, who was in the hospital and it started off very acutely. The second patient, whom we also was in the hospice, the third patient, Rama, is in the community, and we can see that he has been disoriented for few days. This was following seizures and also suddenly stopped alcohol consumption. And then the family was seeing that he was being confused, having wayfinding difficulties. For some time he was okay, for some time he was disoriented, he was being drowsy. Okay, so this is what family members were seeing. Next. So actually, in delirium, the terms are very confusing. So once upon a time, to explain delirium, to understand delirium, it was considered as a clouding of consciousness, clouding of our experience of the world. There's a reduced clarity of awareness or fragmentation of awareness. Nowadays, because it is difficult to quantify, difficult to objectively determine whether someone is conscious or not, this term is removed from the main diagnostic terms in delirium. Next slide, please. So arousal, that is awakenness, is one of the essential feature of all vertebrate animals, including human beings. So there are so in delirium we also see a disturbance in arousal. Based on arousal, delirium is characterized as three types: hyperactive, hypoactive, or mixed delirium. So hyperactive is where we see an increased psychomotor activity. Hypoactive is more of a confusion, you know. Hypoactive is reduced psychomotor activity. Patient appears drowsy, like the third patient. Or it may be a mixed delirium, where there is a mixture of both hyperactive and hypoactive. There are scales which can assess arousal as well, like modified Richmond scale, observation of the level of arousal, etc. Next slide, please. So now we understand that attention, that is the process by which we focus on certain aspects of the environment, and then our brain is in a state of readiness to respond to the stimulus. So attention is some very important and a common impairment seen in delirium. So nowadays we understand that delirium means one of the main cardinal feature is impairment of ability to pay attention. So clinically, when you see people, so you will notice that people in delirium, they cannot participate in conversation or even for a short duration of time. They're not able to pay attention to you. They're not able to participate in conversation with you. So this becomes more evident in distracted environment. If you have to objectively assess impairment in attention, you can ask the person to say months of the year backwards. Next slide, please. The second important cardinal feature that we understand delirium is disorientation or reduced awareness of the environment. So disorientation can be to time, place, and person. So time is the time of the day, it can be day of the week. So when we test for orientation, we generally ask, what is the time? What do you think? What do you think? What day is this today? What is the month? So unless we ask these questions, we may not understand whether patient is disoriented or not. Unless we ask the family whether these days do you know, like have you noticed that he's not knowing when whether it is day or night, then many times family members can tell. So unless we ask we interview the patient as well as ask the family member as well. Both. It should be interview of the patient, family member, and if the patient is staying with us, then it's very important to ask the nurse as well. Has he been knowing the time? Does he know the time of the day? Which day? Like they may know where he is. So whether he thinks he's in the hospital or not. So it's where, so you have to interview the patient, the family member, and nurses who stay more time with the patient or the caregivers, other caregivers who may be staying with the patient. So you can ask to recognize the people around him and where he is, which floor is he, which, what is this place. So is it a hospital? Is it his house? You can ask him if he is not naming it by himself. Okay, which city is this? So this is the second. So most important features are impairment in attention, and the second one is disorientation. Okay. The third slide, next slide, please. Then there are changes in his mental function, like memory deficits. They will not be able to register. So for this, you can ask recent memory. What did he have today morning? What did he have for dinner yesterday night? So these are all things that the earlier to lose, you can check for memory deficits. Language disturbances, unless you ask open-ended questions, we will not really be able to pick up these language disturbances. So if you just ask him, do you have pain? He's only left with answers like yes or no. So instead you have to ask, how is he today? How are you today? So how has it been these days? So you can ask questions like that, which will make the patient to answer in his own words. So where you can pick up incoherence, that is, you are not able to make sense of what he's telling. He's not able to put words in a coherent sequence. So unless we ask patient open-ended questions, this will not be picked up and it will be written as patient is normal, normal and all. Okay, so you have to ask open-ended questions to be able to pick up language disturbances. Then visuospatial disturbance. If you have seen the third patient whom I had presented, Rama, who was in the community, he was having wayfinding difficulties and all. That is because he is not able to, or he lost the ability to know the awareness of the geographical map. The basic map is has deficit. So in the hospital, how do you assess? So we can ask him to draw a clock. So you can tell some time and ask him to draw the hands of when how the hands look like. So this is to look for visuospatial disturbances. Next slide, please. Then they may have perceptual abnormalities. So the first patient whom we have seen, he was trying to pull away IV lines and all. So it's a very commonly seen. So due to tactile hallucinations, so people perceive that there may be bugs on his arms, something that is pricking. So even though there is nothing like that, they perceive that something is pricking. So this is tactile hallucinations. Or people may experience visual hallucination. They may see people, animals, things. It may be lines or even flashes or dots. So which we call as visual hallucinations. And auditory hallucinations. So most commonly, so when we teach psychiatry, we say that if you see visual hallucinations, then you have to rule out organicity. Then auditory hallucinations can generally mean that there may be primary psychiatric disorder, but they can also happen in delirium. That is medical condition, acute medical condition. So you can have illusion. Okay, that is misinterpretation of things like around, like supposing that somebody sees a ivy line, thinking it to be a snake, is an illusion because there is something and he's misinterpreting it. Then the other abnormality can be delusions. Delusions are false fixed belief. These are all revision of psychiatry, I think. So the person may think somebody is trying to harm them or somebody is trying to steal away from them. So most commonly such beliefs may be delusion of persecution. Somebody is trying to harm them. Next slide, please. So let us try to so the next one is they may have emotional changes like may appear suddenly depressed, euphoria, and then it may be lability, suddenly crying, or they may appear to be loss of interest, anger, irritability, and sometimes it may be associated with moaning, muttering, cursing, screaming, etc. Next slide, please. There can be changes in sleep and wake cycles. So common. We see that he has been fine till the evening. Then suddenly these symptoms are more from evening 6 o'clock and all. Because generally there are a lot of there's a lot of activity surrounding in the mornings and which reduce in the evening. So which make the patient more confused. So then the patient sleeps throughout the day and wakes up at night. So he's drowsy throughout the day and wakes up. So all the sleep-wake cycle disturbances are seen in delirium. Next slide, please. So we will go back again. We'll see the patient's histories again. Can you show me the first 3 slides? So now that we went through all the clinical features, we'll again see in these patients what were present. Okay. Can I pick up and randomly ask, is that okay? Is that okay?
Yes, ma'am.
Ashwati, thank you, thank you. Ashwati, Mrs. Dr. Ashwati, are you with me, Dr. Ashwati? Dr. Suma? Yeah, thank you. Thank you so much. So can we go through again what are the clinical features that we are seeing in Mr. Srinivas?
Ma'am, we had seen that the patient was confused.
Mm-hmm.
He was trying to pull away the IV line. So since
that
you had said,
yes.
sorry,
This may be due to
that is probably because of a delusion.
or
That is
or
illusion.
something, or it can be due to tactile hallucinations. It can be visual hallucinations. We don't know unless we ask the patient. Yes, Satira, it may be due to tactile hallucinations. So we need to interview the patient and see. Okay, try to understand why he is doing that, why he is trying to pull away the lines. Okay, then
visual hallucinations.
he has visual hallucination. He's seeing some spiritual persons of the temple.
Yes.
And
he's also disoriented with respect to time, place, and person.
Is disoriented. Yes. Okay, next patient. Can we go to the next patient? Shabna Fatima, Dr. Shabna Fatima, can you tell me what are the symptoms that Kamala is experiencing? What are the clinical features we are seeing in this patient? Dr. Anjana?
Hello, ma'am.
Yeah, thank you. Thank you. Please can you tell me what are the clinical features we are seeing in Kamala?
Features she's having dull aching pain, burning
She's
sensation.
having pain. Okay.
Yes. Then a burning sensation perineal area.
Hmm.
And
Next slide, please.
and she's being restless and trying to get away from the bed.
So this is
And
a kind of these are the symptoms that we see in generally in hyperactive delirium, where there's increased activity levels.
Yes.
Okay.
Yes, ma'am.
Hyperactive delirium. Okay.
Yes,
Then
ma'am. Okay.
then what else we are seeing?
She is not sleeping well.
She's not sleeping, isn't it? So this
Yes.
may be associated with sleep-wake disturbances, may or may not be associated. Okay, if she's sleeping in the day and she's awake at night, it could be that. Okay, then she's not aware of where
she is. She's disoriented.
Disoriented. Next slide, please.
And she's being fatigued. That is, she's become hypoactive, fatigue, and oral intake is reduced. And also, she's having she's agitated and disoriented.
Disoriented. That means intermittently she's looking like hypoactive, and then she's becoming hyperactive.
Yes, ma'am.
Okay. Then other changes we are seeing is suggestive of end of life. That is her pulse volume becoming feeble over time. Breathing patterns are changing, increasingly fatigued.
Yes, ma'am.
So this is more suggestive of a delirium that has occurred towards the end of her life. Yes, and probably because of pain initially, but later is almost looking like a terminal delirium. Yes. Next. Next, who will answer me this time? Shanmuga, Dr. Shanmuga Sundaram. You are with us? Yes,
yeah.
Thank you. Thank you, sir. So can you tell what are the symptoms that we based on the clinical features that we discussed? So what are the symptoms and signs that we are seeing in drama?
Patient is having alcohol withdrawal pattern.
It could be due to. So you are telling me the etiology, isn't it?
Yeah.
So we will go to etiology again. So what are we seeing in this patient? What are the symptoms and signs we are seeing?
Drowsiness and
he's
confusion.
Being drowsy, he's being confused. Okay.
And disoriented to place.
So this is more of a hypoactive, isn't it? And he's becoming disoriented to place. And he's having some I have written some wayfinding difficulties, isn't it?
That is to place.
So disorientation to place means he doesn't know where he is. Wayfinding difficulties, it is not geographical orientation is not proper.
Spatial orientation.
Spatial orientation is spatial. Okay, next slide, please. Thank you, sir.
Yeah.
Okay. Then we will go on to see. Next slide, please. Next slide, please. Slide. Next. Next. So, previous slide. Previous. So, whenever we see people with delirium, we have to interview the patient as well as the family and nurses. It may happen that when you are interviewing, he appears very fine. So it's very important to interview the family as well, and then take the observation by nurses very seriously. And then you have to see the why. So the examination mainly you have to importantly assess for vitals, okay, especially oxygen, then whether there is any tachycardia, BP, then test for CNS functions. So this is especially if patient has come with acute onset of these changes, you have to look for all the CNS functions, including, that is, you have to test for motor power, everything. Along with, you have to also examine for extraocular movements, tremors, then myoclonus, asterixis, Assess for pain. So patient may not be able to tell pain. Then we have to look for non-verbal signs of pain. That is, patient may be crying. Patient may have tears. Even the patient is not able to tell us. Patient has tears. Patient is restless. So these may be non-verbal signs of pain. Then look for sensory deprivation. So ask whether patient has been using spectacles, hearing aids before, and tell them to give back again. And review the we have to review the treatment chart. If there are any new medications, any medications that have anticholinergic properties that can push the patient into delirium. Next slide, please. So we'll come to this later. Next slide, please. So delirium, if you see in the community, okay, more than 85 years of age, more than 10% of people experience or are in the state of delirium. It is higher in geriatric ward, medicine ward, and high. It is very high in. It is not 20 to 30%. It's very high in ICU and palliative care setting. Next slide, please. The onset, based on the onset, we may think of what may be the etiology. Generally, if the onset is very fast, within seconds and all, it can be because of seizures. Within minutes to hours, we see delirium onset in infarcts, CVA. And if it is gradual in onset, it can be due to primary tumors or metastatic tumors within the brain, or it can be because of substance withdrawal. Next slide, please. So generally, we see delirium commonly due to alcohol withdrawal. It's generally onset from 3 to 5 days. Most commonly 3 to 5 days. After stopping alcohol, we see patients experiencing delirium. The course is generally fluctuating in nature. As I said, the person may be completely fine and then intermittently going into delirium within a few hours, as little as 3 hours. Or there may be diurnal variation, worsening towards the evening. Then duration also depends upon the etiology. So generally acute onset of delirium, they last for shorter times, but chronic delirium, which may be due to lesions in the brain, tumors in the brain, they may go on to be long as well. It may last for weeks to months. The resolution, as I said, if it is withdrawal, substance withdrawal related delirium, it generally recovers, but something that is related to tumors, it may worsen and progressively evolve into stupor or coma. Next slide, please. So the risk factors for delirium are elderly age. So delirium can happen in anyone. So I think most of us must have experienced delirium when we had some high fever, isn't it? High grade fever. Then we all experience confusion transiently. So it can happen in any age. However, it is more common in elderly people, and especially if they had cognitive impairment in the past. So generally, if the patient had some memory difficulties in the past, or if they were diagnosed with dementia or cognitive impairment, or if there is a history of delirium in the past. Generally, those who must have had low performance status till then, must be immobile, sensory impairment, dehydration, malnutrition. So these are all risk factors for delirium. So medication, some of the psychiatric medication and some non-psychiatric medication as well may predispose the patients to delirium. Advanced illnesses, coexisting medical conditions. Next slide, please. As some of you pointed, it can be metabolic reasons, electrolyte abnormalities, then respiratory disturbances, hypoxia, hypercapnia, infections, liver or renal dysfunction, anemia, dehydration, deficiency of vitamins. So we have to see how has the onset been. And next slide, please. So I have written a small mnemonic. Next slide. Next slide, please. I will show you. So if you can remember as delirium. So D for drugs. So you have to see which drugs may be responsible. E for electrolytes. L for lungs, hypoxia or hypercapnia. Infections, urinary infection, respiratory infection, or infarction. If it's acute onset, you have to be very careful to rule out CVA or other cardiac, or it may be a cardiac events. Yes, it can be arrhythmia. So it can be any of those. Then retention of urine. So urinary retention. So sometimes we will see that patient is confused. Then patient's Foley's catheter is not placed while bladder is full. So once you place Foley's, after a few hours, patient is fine. So it all appears like delirium. He's restless and all. So the reason may be there is retention of urine. Constipation. Constipation is very important reason. So even the first patient I have been discussing, no, Srinivas, in post-operative state, he also had one of the main factors was constipation. It can be restriction of mobility. Then I is impairment of senses. Can be untreated pain or it can be metabolic conditions. So previous slide, please. So it can be next slide. Yes, this one. So it can be due to tumors within the brain. Either it is primary tumors, metastatic tumor, it may be a paraneoplastic syndrome or hormone secreting tumors can all produce delirium. It can be due to drugs as well that we discussed. Chemotherapy, steroids, irradiation to brain, opioids sometimes can themselves cause delirium. Antidepressants, especially benzodiazepines, then stimulants, anticholinergic drugs, alcohol can all cause delirium. Next slide, please. Next slide. So whenever we assess it, I told you this. Next slide, please. Next slide, please. So there are some standardized scales to assess delirium, like confusion assessment method. So you can find a good interview of confusion methods. These are there in the YouTube, which assess the various aspects of delirium. So once you see it, you will get an idea, able to perform it structured way. Possible, I will also share one such good video with you. Then 480 nursing delirium. However, it is important to remember that none of these scales can replace a good clinical examination. So of all these, the most important and vital thing is a good interview and examination will give most of the time the reason why a patient is in delirium. Next slide, please. And also identify delirium. So more than any scale, it is very important history and examination. So basically, whenever we see a patient in delirium, we ask the first line test. That is, first line test will be CBC, ESR, and peripheral smear to look for any infection. Okay, electrolytes, serum, the sugars and ketone bodies, urine routine and microscopy, then renal function test, bilirubin, chest X-ray. So these are the first line tests that we will get if we see any patient in delirium. So most of the times, if we correct this, delirium corrects. So especially in we see patients most often in the lower socioeconomic, middle socioeconomic status. So these are the, like, many times will fetch us the diagnosis. Next slide, please. The reason. But sometimes if we are not able to, the delirium is not at all resolving and we are not able to find reason, then we go on to special tests like calcium, magnesium, plasma, ammonia, and ABG. If this is a patient with respiratory conditions and all, then ABG, urine, blood and sputum culture, ANA, MRI brain. If you suspect an intracranial pathology, then so it should all be, it's a supplement to examination. So if you think that there is some intracranial pathology, then we will go on to imaging. Then ANA levels, EEG. EEG again, it's not very commonly done. But if you think that seizures, ongoing seizures may be the only responsible cause, then we may go for EEG. Not very viable most of the settings, or getting drug screens. Next slide, please. So it is important to remember that prevention is the key. And very commonly, multifactorial etiology is the most common reason why a person is in. Next slide, please. The principles of treatment of delirium will be, next slide, we'll go on to this next. So the principles of treatment is mainly non-pharmacological measures will be to provide a quiet and peaceful environment, educate the staff and the family regarding this condition. Then orientation by family and the staff. You can place a calendar and clock nearby, correct any sensory deprivation, early mobilization. Okay. Previous slide, please. Previous slide. So especially in terminal delirium, it is very important to explain the family what is happening to the patient. So because it is very distressing for the family to see patients in delirium towards the end of life. So it may be fluctuating. For some time he may be fine, then again he appears confused. And I have seen one family which were stigmatized because of patient was confused and talking irrelevantly. So somebody said it's a psychiatric problem and all. They became very stigmatized by that. So it is very important to educate that the patient, the family, and explain that it may happen in a few people that at the end of life we may pass through delirium. Next slide, please. Very important to be supportive in these conditions. Next slide, please. And also explain the staff that the patient is in delirium. Sometimes the nursing staff may not be aware, especially the young trainees and all. So we have to educate that this is delirium. So they keep shouting on the patient, family and all. So it's very important to educate the staff as well. Okay. So if I have to just make a small mnemonic for what you have to do, to feed, hydration and nutrition, reorientation, ambulation, and ensure that he'll sleep, especially towards the night. Next slide, please. Pharmacologically, so antipsychotics are the main drugs that we use in delirium. However, so they have to be reserved for a few conditions that I will go on to tell in the next slide. Generally, we avoid benzodiazepines. So dexmedetomidine is something that is tried in the ICUs. Okay. Next slide, please. So dopamine antagonists are nothing but antipsychotics. So they're mainly given when patient is experiencing very distressing hallucinations and delusions, or if the patient is aggressive and is at a risk of harm to self or others. Only in that case, we go for antipsychotics. Because we have to assess the risk versus benefit. Always before giving any drug, the risk and benefit. Explain the family also that patient may become sedated, drowsy, especially towards end of life. It's very important to explain the family that we are giving it to reduce agitation and hallucination. He may become drowsy, and preferably give a lower doses because the extracellular volume also reduces, the dose requirement also reduces. So haloperidol and all we can give. Haloperidol is the most commonly used drug. Can give 1 to 5 mg. So depending upon how aggressive or how fast you need to control. So 1 mg, generally it's given as 1 mg. Then we can give quetiapine as well if the patient can take orally 25 mg and then can repeat after 1 to 2 hours. Then the maximum doses that we can use are haloperidol up to 20 mg, quetiapine up to 200 mg. Then risperidone is also you can give 1 mg or 2 mg. So again, it's important to remember that they may become very sensitive to antipsychotic, become drowsy. Then family members may again become very anxious while the patient is sleeping and also you have to very careful before giving antipsychotics. Explain them and give. Next slide, please. So haloperidol can be given orally, can be given intravenously, it can be given subcutaneously. So all these three, oral, IV and subcutaneous, are available for us right now. So it is, we can give 0.5 to 5 mg, 6 hourly and even up to 4 hourly as well. So it can act as an antiemetic, as you may learn in the classes on nausea and vomiting. Haloperidol is also an antiemetic. Then lorazepam, generally lorazepam and diazepam, we give it in substance withdrawal delirium. Okay? But sometimes, if the patient is very anxious, then we may also give lorazepam in patients with other causes of delirium. But generally, we prefer to give haloperidol over giving benzodiazepines. Next slide, please. So the bottom line is you have to find the cause. So even though we are giving medications, this is only to, it is something like just treating the agitation, aggression, and hallucinations. So if there is a fire in a room, you are just opening the window so that the smoke can go away and you can see more clearly. So it is only to remove the smoke in the room by giving antipsychotics. So, but you have to find the reason where that fire is coming from. What is the reason for the delirium? So that is the most important. And non-pharmacological measures like reorientation, ensuring hydration, and finding the cause and treating the cause is the most important. Let us see if we will be able to identify some causes in the patient's 3 people that I had discussed initially. Can you go back to the first slide, Srinivas's slide? And what we will do for these patients, what investigations we will send, we will see. Okay, let us see. We will be able to think over these patients. Dr. Snifa, are you with us? Dr. Snifa? Dr. Anil? Dr. Anjana? Dr. Anjana, thank you. Thank you again. So can you tell us, can you think of what may be the reasons why Srinivas may be in delirium? What may be the causes?
It may be due to any metabolic imbalances like low sodium level or something.
Can be due to metabolic imbalance. So you have to, so whatever we have discussed, we have to personalize to this patient, isn't it? So
Yes,
based
ma'am.
on his history, his presentation, we have to personalize. Now, he had a history of fall, he underwent surgery. Do you think pain can be the reason why he may be disoriented? So we have to see the most common causes possible in one patient, isn't it?
Yes,
So
ma'am.
can pain be a reason?
Yes, ma'am.
Okay, pain can be one reason. What else
Okay.
may be the reasons why he's in delirium?
Tactile
So
hallucination.
tactile
Because
hallucination is a symptom,
Yes,
isn't it?
yes, yes,
So
yes,
Atira is telling it may be because he's immobile, he has constipation. Yes, very good. So these may be the reasons. He's in a new place. As somebody said, no, initially, he's in a new environment. He's in the ICU. Then there is no cue from the outside, whether it is day or night. So the environmental reasons may be there. Okay. Pain may be one reason. And what else it can be? He's on catheter. So there may have been block in the catheter.
Okay,
He's trying to pull it out. So
Yes,
we
ma'am.
have to find. Then what else? Somebody suggested can be constipation. Yes, actually in Srinivas, I got to know he had constipation. So we treated constipation, and then after that he was a little fine. So the next. Thank you, Anjana.
Okay, thank you.
Go on. So we will first try to identify what may be the causes, and then as you said, we may check for electrolytes and see if he is developing infection. Okay, because he is in the post-op state, it can be respiratory infection. So we have to ask for chest X-ray. You have to examine first. Okay, but as well as get chest X-ray. Okay, first line investigations we usually send. Okay, next slide, please. The second patient. So what may be the reasons for delirium in this Kamala? Dr. Roni Bala? Angam Roni Bala. Can you think of what may be the reasons for delirium? Pain, very good.
Pain, madam.
Pain can be a reason. Okay, very good. Maybe untreated pain was causing delirium in Kamala. Next slide, please. Then, what else may be the reason? Next slide, please. So after pain improved, after starting fentanyl, then again she was becoming disoriented. Kidney function test should be done in Kamala. Okay, very good. So why do you think we have to do kidney function test? Very good. Because why? Can you tell us what is the reason why we will do kidney function test? Yes, Sinha.
As it is a CA cervix case, so 1/3 of the CA cervix case we see kidney function like impairment due
Very
to
nice.
maybe obstruction in the ureter or at that level. So
Very
that,
nice.
and one more reason here, we can do MRI brain also. Just to suspect that if patient is coming in delirium state, just to see that whether any metastasis has happened there or not. It's just like that.
So I agree with you on the first, Priya. So I agree with you that we have to do a kidney function test, possibly. Very good. But regarding MRI brain, anyone has any other opinion? Should we get MRI brain, Kamala? Anyone else? Do you think we should get MRI brain?
Not necessary, madam.
Not necessary.
Usually,
Why?
CA cervix doesn't spread to brain that easily.
So we have to see whether there is a possibility that she will have a brain mets. Any other reason why we will not? Why do you think we will not? Yeah, very good, Atira. So see, you can see that there are other changes in Kamala. That is, she is becoming feeble. Pulses volume is becoming feeble. Breathing patterns are changing. So all these are suggesting of end of life changes. So when it is like that, even if we get an MRI, let us say if you find some brain mets, do you think we will go for radiation? So generally they will not go for curative treatments, isn't it? So there is, when you can find no benefit of doing investigation, then it's better to withhold. I mean, better to not expose the patient to investigation, because it is also not, it's a burden to the family. As you know, she is a fish vendor. When we can find or think of no benefit for the patient, then we will not get those investigations. Okay, generally when we get any investigation, we have to think what will be the result and what we will do with the result as well. Next. Rama's case, who will tell me what may be the causes in this patient Rama? Dr. Lisa, you're with me? Dr. Lisa? Can be infection, very good, because he has cough. It can be alcohol withdrawal, very good. Next, can be seizures, okay. So ongoing seizures, okay. Next, infection, very good. So in this case, you can see that in Rama's history, there are multiple causes, isn't it? We had alcohol withdrawal, following seizures. It can be the drowsiness, multiple following seizures. Okay, so there are multiple causes which are causing this picture of delirium. Nutritional deficit, very good. So you can see there are multiple causes in Rama's case. So most of the cases will be like this, multifactorial etiology. Okay, now we can see the patient that has been brought to us for today's discussion. Then similarly, we'll try to analyze that patient as well. Okay, is that okay? You're with me?
Thank you. It should be like your suggestion should be good. Thank you for taking us through with the case discussions. No, that is what is really helpful. So which makes them analyze, and then as we see the cases, will give them more confidence and things to do. So thank you very
Thank you so
much. And as you suggested, we can go ahead with the case presentation and then come back to the discussion, as you say, with the cause and then management. Sangeet, are we ready with the case presentation?
Yes, ma'am.
Okay, then go ahead.
So Dr. Shapna Fatima will present today's case.
Go ahead. You
Good
want
evening,
the
all.
Sangeet to share the screen?
Yes, ma'am, I will share from mine.
Yes.
Good evening, all. I'm Dr. Shapna Fatima from the Department of Oral Medicine and Radiology. For today's case presentation, we have a 75-year-old female patient who was diagnosed with pneumonia and delirium. The patient came to the OPD with the complaints of cough with sputum, which was for the past 1 week duration, and patient had history of difficulty in breathing, chest pain, also had fever for the past 3 days, and she was also noted to be restless and agitated. For the history of presenting illness, there was gradual increase in the severity of cough. Fever developed 2 days later. Patient had a history of wheezing, and also she gives a previous history of anxiety and irritability during infection. For the medical history, she was diabetic and hypertensive and was taking medication for both the conditions, and also she was asthmatic and was under inhalational steroids. On general examination, she had a temperature of 102 degree Fahrenheit, and she was having tachycardia around 115 beats per minute, and also her pulse rate was increased to 112 per minute. Her respiratory rate was 22 per minute, and oxygen saturation was 94%. She was on this respiratory distress, and also she showed physical signs indicative of delirium. And routine investigation was done. A chest X-ray was taken, which was consistent with pneumonia. A complete blood count showed elevated WBC count, which was indicative of infection. Sputum culture was also done, and her mental status examination was indicative of delirium. The treatment for the underlying condition, that was treatment for pneumonia, was done, and for any other drugs, there was discontinuation of any unnecessary drugs. For the outcome, the patient's delirium improved as her underlying infection was treated, and she was discharged home after a few days. Coming to the psychosocial aspect, she was a widow for the past 10 years, and she was staying with her son and family. She was from a financially stable family, and patient also had previous history of irritability, anxiety, confusion, and mood swings or mood changes. So the main concern of the family was that patient feels weak, confused, and disoriented when she was having any infection, and also she was unable to take or follow any commands. To summarize, with 75-year-old female patient reported to the clinic with cough, fever, and chest pain. Patient takes medication for hypertension and diabetes and was non-asthmatic. On examination, she was on respiratory distress and was confused. Routine investigations indicated pneumonia, and her mental status examination was consistent with that of delirium. The underlying infection was treated, and the patient's delirium was improved. For the discussion, we have that what can be the possible causes of delirium, and also can the patient be back to her normal self without medication? Thank you.
So for the discussion, I invite again maybe Dr. Tanya Kumar. What can be
Good
the
evening, ma'am.
possible good evening. Thank you. So what are the possible causes of delirium in this patient?
Ma'am, the main cause of delirium in this patient is infection itself. Because the history, it's evident that whenever she gets any sort of infection, she has a tendency to go into a state of delirium.
Very good. So respiratory infection leading
Yes.
to probably hypoxia, hypothermia might have been the reasons why she must have had delirium. So previous
ma'am.
history of emotional changes. So do you think that previous history of emotional changes can cause delirium? Anyone can think of by any emotional reason? If there is a history of depression, do you think that will predispose to delirium? No, it is not depression. But if there is a previous history of cognitive impairment, memory deficits, past history of delirium, okay, they can all cause delirium, but unlikely. So emotional changes can be a part of dementias in the elderly. So supposing if it is a frontotemporal dementia, patient may be having some emotional changes for the last few years, but that is different from say past history of depression. That may not be a predisposing factor for delirium. Hypoglycemia history. Okay, so we have to look if there are any
Metabolic
hypoglycemic
causes.
changes. Very good. So you have to check for because infections and all there can be increase in sugar levels. So as you said, metabolic abnormalities like sugars increase or reduce sugars, electrolyte abnormalities, ECG should be done as she is a diabetic and hypertensive. Very good, excellent. Then fever can be a reason why she has delirium. Very good. Okay. Then any other reasons why you think she may be having delirium? So before that, so she has said, before we go further, I am just interested to know, in case this is the history that was given to you. You are the consultant and your PG has presented to you this history. So what will further will you clarify in history for this patient? Dr. Angom Ronibala. So what further questions will you ask to the patient or the family? Because our presenter has said that there was history or there was MSc was suggestive of delirium. So what are the findings in history? What questions will you ask? And what will you look for in these patients? Because we discussed also, right, in the class, the clinical features. Let's want to just revise. Past history of dementia, okay. Good. Then any changes in cognition, very good. Memory deficit. So you will check if person is having any recent memory deficit. We discussed no in one slide changes in cognition, memory deficit. Is there any visual spatial disorientation? We'll check, isn't it? Very good. So to look for the cognitive changes of delirium. You will look for causes, dehydration. No, I'm asking you about clinical features. What? Very good. You will check for any change in sleep-wake cycles. Okay. Then, so I'm asking you what clinical features will you look to think of delirium? So that is why. Change in sleep-wake cycles. What else you will look for? So you can ask, so somebody said, I will check for cognitive changes. So you can ask, what did you have in the breakfast? What did you have yesterday night? So all these things can suggest whether person is having recent. So when you go for rounds, let us say you are a pulmonologist. So generally you will check whether patient has cough has improved, whether he has fever today or not, isn't it? Along with that, you can ask the patient whether what did you have for breakfast today? What did you have yesterday night? Okay, so this can give a clue to recent memory deficit. Okay, so you can ask and look at the family whether they agree with the patient or not. Okay, so then you get a clue regarding memory deficit. So you will look for perceptual. So you can ask how he has slept yesterday night. Perceptual abnormalities. Very good. Whether he is having some perceptual abnormalities. Very good. So when you go for rounds, patient is picking up on his blanket. Okay, so you can understand that it is a perceptual abnormality, his disorientation, hallucinations. So you can ask the patient whether you are seeing something or hearing some people who are not there. You can ask whether he has passed motion, whether he has passed urine, check the urine out. Very good. What else you want to check? Disorientation, arousal, whether he is being drowsy, unusual. Yesterday is fine, then he's becoming drowsy. Very good. What else you will look for? So these are all you have to give a good observation whenever you're going for rounds, irrespective of whatever branch you're in. So you have to have an observation of the patient. General, how is the arousal levels? Okay. Then what else you will look for in this patient? Or what you will clarify from your PG. Next slide. Next. Anyone else? Any other answers? Dr. Pradeep, medications, very good. You will look what the medications patient is on. Any recent change in medications. Okay. Then mobility. So if your so it is very important to ensure that patient get physiotherapy or some movement. Encourage the patient to walk if it's a ward, general ward and all. Very good. Lability of mood. Patient is crying suddenly. Okay, all these things you have to look for. Very good. Then so what the mind knows, your eyes see. That's what we say learn in medicine. So now that we have all discussed delirium, I'm sure from tomorrow you'll look for these changes. So then if it is a substance, so you also have to look for other symptoms like tremors and all. Okay, especially acute like orthopedics and all. Patient may have suddenly come with a fracture. He may have been underwent emergency surgery. Nobody thinks of whether he had history of use of alcohol. Then we get referral on day 2, day 3, saying that he's shouting loudly, hitting family and all. That is because alcohol withdrawal was missed. Okay. Thank you very much. So the next, can the patient be back to her normal self without medication? So who will answer this question? Dr. Pratibha? Dr. Anshita?
No, ma'am.
So can the patient be normal without medication?
No, ma'am. In the acute stages, we have to give some medication.
Acute state. So if the patient has aggression, it's aggressive, hitting family members and all, yes. But if the patient is drowsy, what, do you think we have to give medication?
No, ma'am.
No.
We can correct the factors responsible for that.
Correct. Very good. Excellent. So you have understood very nicely. So if it is a hypoactive delirium, we should not give any medication, treat the cause. But if it is a generally hypoactive delirium, it is missed because patient is also calm. So no, everyone thinks he's fine. Okay. So because generally we don't have time to interview at length, look at how is the patient's language and all, whether there is any incoherence of speech. So it is mixed. Most of the times it's hyperactive or mixed delirium that is identified by caregivers or family also. Otherwise, everyone thinks it is normal. Patient is fine on. Okay. So, so if it is a hyperactive delirium, if it is the patient is aggressive or the visual hallucinations are very disturbing. So, patient supposing say just has some visual hallucinations, but it is not disturbing, it is not distressing, then you may not give medications. Okay. Because otherwise you are confused whether your haloperidol is making him drowsy or is it some other metabolic factor that is making him drowsy. Okay. So you have to, unless patient is aggressive or harmful and all, will not give medication. But for sleep you can give in the night, quetiapine, etc. Okay. Then, so what do you think in this patient? In this patient, can he become normal without any medication? Pratibha, in this patient, should we give any medication? Dr. Pratibha, you were answering.
Yes, ma'am.
You have to give medication. Can you go back to the slide? The slide where the patient had clinical features. Can you go back? Can you display the slide of clinical features?
Sangeet, can you go back to that case presentation? Sangeet, are you getting or?
It's fine.
Okay.
Not this one. The case, the second, the case we were discussing by Dr. Shabna.
What we did, the case presentation for the day.
Is it now visible, ma'am?
Yes.
Okay.
Go on. Go to the third or fourth slide. No, wait.
So do you think you want to give medications, Dr. Pratibha, for this patient?
Next slide, Sangeet.
Ma'am, in this case, I feel delirium may be due to some sort of hypoxia, ma'am. First, I will correct this, and if it's not controllable, then we can give mild doses.
Excellent. So it is due to hypoxia. Okay. So Dr. Shabna, was the patient hyperactive or hypoactive or mixed? Was there any?
At times she was a sort of silent, and at times she used to speak to just speak like that.
Okay. Speak like that means, was it disturbing?
No, she was she was sort of calm most of the time.
Most of the time she's calm. So in that case, when she's calm, we don't need to give medication. So our benzodiazepines, the main group of drug antipsychotics will not correct calmness. They will only correct aggression. As I said, it is only it's like an outlet. It's like a window to the room with fire. Okay. So you cannot stop the fire with help of antipsychotics. So you have to treat the cause. You have to give antibiotics, oxygen. Only when they're restless and agitated, aggressive and all, then we can give some medications. And do you think that we can stop them, Shabna? Suppose the patient became restless, so you gave quetiapine, patient was fine. Then do you think you will stop the quetiapine or you'll continue, Dr. Shabna? What do you think now?
Sorry, ma'am, can you repeat?
Do you think so? Patient has become fine after 10 days. Patient has stayed with you, let us say, for 10 days. And then you're discharging her. So will you continue quetiapine?
No, I think we should stop it.
Very good. So you got your own answer. So these are all acute states, okay, for which we will give medications for the transient state only. We will not go on and on. Not even 10 days. Maybe next we'll give SOS, or even if the patient is very agitated, very restless and all, you may give for few days and then try to stop and see. Okay. So these are not medications that you'll go on. Okay. So it's the transient states. Delirium is transient. Any other, anyone wants to bring any other questions, your experiences, any queries, want to add something?
Madam, I have one question.
Yes, please go ahead.
So this is a patient, aged patient, who had been taking this for his insomnia for like the SSRI and antidepressants, clonazepam and escitalopram. So he's been using for several years, and recently he has developed a few symptoms like visual hallucinations and then disorientation So how to look and how to go about it? Should we stop clonazepam and SSRIs and go for antipsychotics, or how to go about it?
Okay. Thank you for the question, sir. So, why do you? So he has visual hallucinations, isn't it?
Yes, ma'am.
Has visual hallucinations and disorientation.
Yes. And
How
also
old?
memory loss.
Memory loss. How
Yes.
old is he?
84 male.
84 years old. So now we have a patient who is 84-year-old male and who has recently developed visual hallucinations, disorientation, isn't it? And
Yeah,
what else, sir?
memory loss.
Impairment. Memory impairment. Okay.
Yeah.
So now we will see from anybody can answer what we will do for this patient. We will see from the audience here. Anyone? What do you think we can do for this patient? Dr. Kaushik, Dr. Anju Matthew, you're with us? Anybody has anyone else? You would like to ask any more questions for this patient? What do you think you will ask for this patient? Dr. Atira? Yes. Check for sensory impairment. Very good. Okay.
Hello. We can check for the visual and the audio aspect of the patient.
The patient has it. Very good. Visual and sensory impairment. Then
the patient is 84 years old. We can check for any anemia related cause. Then metabolic dystonia, CKD or something like that.
Very good.
To rule out any infection. Then it may be related to age-related Alzheimer's-like of changes.
So you have to ask about first what you want to ask history about. Yes. So we have started with onset, no? Isn't it? So we have started our class with onset. So do you want to ask about the onset?
Yes, ma'am.
So what do you want to ask regarding the onset, Atira?
How long it happened?
Okay. Doctor?
Sudden, gradual.
So was it sudden or gradual? Can you tell us more information?
Yeah, about the patient is diabetic for more than 25 years. And
no, the visual hallucinations has
so
been sudden or
no, it's yes, almost sudden only, because suddenly one day they found that he was complaining about this thing.
Suddenly the patient is having visual hallucinations.
Yes.
So if there is almost a sudden or acute onset of symptoms, what are the causes that you will think of, Dr. Atira?
Metabolic disturbances.
Metabolic disturbances.
Then, she's diabetic.
The first slide that I have shown onset, anybody remembers the onset slide? Hyperacute is because of? Hyperacute seizures. Very good. Acute onset?
Infarctions.
Very good. So this is an 85-year-old male who is having almost a sudden or two acute onset of symptoms. So it can be because of infarcts, CVA in the brain, isn't it? So there are different types of infarcts as well. So there are large infarcts, there can be small infarcts. Okay. So if there is a large infarct, then it also depends upon the location of the infarct. If it's a huge CVA, you may see a hemiplegia, hemiparesis, loss of consciousness, all those things. But if the patient is having small infarcts, what we call microinfarcts, so sometimes they can have this kind of visual hallucinations or confusion for a few days. It can happen like that. So it can be like those. What else can be the causes in this patient, Atira? What else you want to ask for? So onset is one. Then what else you want to ask?
Whether it is increasing, how the symptoms are progressing.
Yes, whether it is fluctuating, how is the progression you want to know. So is it symptoms fluctuating? The disorientation is fluctuating?
Yes, ma'am. This is sometimes like for 2 days the symptoms will be there. Then again next few days
Not there.
there will be no
Okay.
symptoms. Again the symptoms comes back.
Now Athira also wants to know what has been the duration of these symptoms.
For last 6 months.
Last 6 months. 6 months
Yeah.
is having these symptoms. Okay.
Yeah.
So they have started suddenly and have been there for the last 6 months. Okay. What else you want to ask, Athira? Anyone else wants to ask anything?
Any change in medications of the patient?
Very good. So has there been any change in medication? So he has told us that benzodiazepines were there. Patient is on escitalopram. Then
Yes.
any recent change in medication?
No. Only those these two means the combination acetylprom and benzodiazepine. They were independently they were advised. Means they were saying asked to take but the patient was he wants the medicines regularly, but the family members they gave him intermittently. Maybe one day they have given, then they stopped for 2 days, and then those because they were thinking that maybe due to this SSRIs and this medications he was having this, so they were intermittently they were giving.
From how
And
long has he been on these medications?
many years. That's maybe more than 10 years.
More than 10 years.
Yeah.
So if a patient is for more than 10 years on the medication, then we have to see how much risk really now it is because of those medication that he has delirium. But nevertheless, so it can be because of medication. Escitalopram also has, so whenever you see a medication, you can see whether it has any anticholinergic property or whether it has any property of causing urinary retention or bowel retention. So if any of these things are there, then you can think the drug may be or the benzodiazepines. Okay. So they can also cause, but you have to give it a really reasonable trial. You can stop and see, but before that you have also to understand what was the reason why that medication was started. So what was the reason the medication was started?
Due to insomnia.
Due to insomnia. Okay. So now how is the patient's sleep in general?
Yeah, the sleep-wake pattern is again disturbed. In spite of having these medications, the sleep-wake pattern is different. It's been altered. Sometimes he's sleepy at night and the next day he's okay. But sometimes the whole day he's awake. Even at night also he's awake for maybe 2 nights he's awake, and and then subsequently the other third night he falls asleep. So it's a very altered pattern of sleep and wake pattern.
So what was the dose of escitalopram and clonazepam?
The combination dose, I think 0.5 and 10.
So generally for insomnia alone, escitalopram will not be prescribed. There is a depression and all may have been prescribed. Okay. But if it was a given reasonable amount of time, like 10 years back, he had a depressive episode, then and if it was only one episode in his lifetime, then you can stop and see. Okay. But you have to stop escitalopram little gradually to make it 5 and then stop. Clonazepam you can stop because it's only 0.5. But then you have to help him sleep as well. So you can give him some quetiapine or you can give him melatonin to help him sleep. But at the same time, you have to look for other causes as others have suggested here. If there is any intracranial lesion, if there is an infection, so you have to look if he has developed any pneumonia, urinary tract infections. Okay, so all these things you have to look for. So you have to you have to do a general physical examination. All the signs that I have done, look for the causes, the delirium that I have said, that as well as send the basic panel of investigations. Okay, that we discussed earlier.
Okay, ma'am.
So what we do generally in such a case is look for all that, but at the same time, you know that these may have anticholinergic properties. Stop and see. Don't know. Okay, it is a multifactorial etiology in general. But as you have been saying, he has some memory difficulties. So it can be a part of dementia. Patients who have dementia have a slow onset of recent memory deficits. That is, they forget what they have happened just a few hours back, what had happened. So it starts off as recent memory deficits, then progresses to long-term deficits. Then they may also have visuospatial problem. You can ask him to draw a clock. You can give him 3 words and ask him to recollect. So it can be a part of the dementia that patient has delirium. So if it is the reasons may be that he is having maybe a part of dementia. It can be a part of medications, or it may be a recent infection. So we have to examine the patient and see what is causing delirium in this patient.
Okay. Okay, ma'am. Thank you. Thank you, ma'am.
Anyone else want to discuss something? Even the first case that I presented to Srinivas, it took us a long time for him to get out of the delirium. So because of that, he also had problems in rehabilitating. As you know, post-operatively, they have to get mobilized, take a good physiotherapy. Otherwise, the surgery will go futile. But he was in a delirium for a lot of time, probably. That's the reason he did not get physiotherapy. So outcomes are bad whenever we do not identify and they're not able to treat delirium early. So elderly people and all to be very careful and look for delirium.
Thank you, Dr. Sravani. As you said, it's practically what it is. It takes time and it has multiple causes, and they may be interconnected also. As she said with this patient, you have to correct that for having rehab. First, until and unless that doesn't happen, the rehab. So the purpose of him having the surgery is to mobilize and get better so that he doesn't get pneumonia. So that's why in elderly care, each one is interrelated. So working together, most of the places nowadays, any of these orthopedic centers will have a geriatrician with them. Mainly to assess them for any surgery and also to manage them post-operatively, because electrolyte imbalance, renal function and all, they are very much abnormal with people who have multiple non-communicable diseases like hypertension, diabetes and all. No, they are all prone for metabolic disturbance. And then not only metabolic, this is renal impairment. So any medicine you give, see that renal impairment, not only for that particular medication, any medication they are having can act for longer period of time. So all these, that's why treating elderly is not by itself, and you have to remember everything and going back and checking all this, and on top of that treating, see, delirium, dementia together, it's a wrong combination, or it will take long time. See, the case which we took up last 6 months, he's been having all this. And he also said that sometimes, like, he may be by himself or someone has to give medicine, 50% he gets medicine. So this symptom has been building up.
The medications are one important reason. Like most of the elderly we see, they bring us a bag of medications. So they might have gone to respiratory medicine because he's having some cough with sputum and he's on levocetirizine. And then he will go to the urologist saying that he's having difficulties in passing urine. Then he's on other anticholinergic. So everything adds on each other. Nobody looks to what all medications he's on. Sometimes you will see 15, 16 medications if you write the entire prescription. It's very important to go through all the medications and to see if he has any memory deficits, because it may happen that they may over-medicate themselves or under-medicate themselves. Who is supervising medications and all, especially in elderly people.
Exactly. So that is very, very important that you need to go through. And then see, and they'll be seeing so many doctors, so they also will be confused. So that's why we always say compliance, drug compliance. No, only when you sit and ask, of the 15, 5 only they may be taking. And they'll say, this doctor told that, and then when I went next. So even last week when we saw one patient, a very nice carer, but she did not know what to give, what not to give. So we had to sit with her. Exactly what she said. When she's seeing the second doctor, first doctor medication she was missing. So can't blame them, but also so many things, no? So drug interactions, missing something very essential can have an impact also. Okay, so always go through, find what is the cause, then treat. Just treat, knowing this, like pharmacological, non-pharmacological alone won't do. You have to get the diagnosis, then management, then go. And as Dr. Sravani said today, you need to know first, then you treat. If you know only, then you look for. We normally used to say, what the head does not know, the steth will not hear. So like that only. The same thing holds good for every aspect or every symptom. Thank you very much, Dr. Sravani. Does anybody else wants to ask anything else? We have gone through all the questions and queries in the chat box also. So once again, a big thank you for taking us through case discussion. That is a good way forward. And I pass it on to Sangeet, please.
Thank you, ma'am. Thank you, Sravani, ma'am, for the wonderful case presentations. Thank you, Radha, ma'am, for facilitating the whole session. Thank you, Dr. Shapna, for presenting the case. Thank you all for participating actively in the session. Thank you. Let's see in the next session.
Thank you all. Thank you.